Very welcome to this third lunch seminar in our series on current challenges in biomedical information technology. Today the idea was that we as usual should have two speakers, but unfortunately Stina Svensson is ill and will not make it here today, so Päivi Östling will be the lunch seminar presenter today. So I leave the word to you.
So I moved to Sweden 3 months ago, but I have been working at the Science for Life laboratory in the laboratory of Olli Kallioiniemi since 1st of September 2016, so 2.5 months ago. And I work as a co-PI, and my task is now to set up our research group here in Stockholm. And I was asked to talk on the title of personalized or individualized medicine, and I took the liberty of adding urological cancers to it, since that's really where my speciality and knowledge is on. And in urological cancers we mean prostate, kidney and bladder. That's going to be the focus of the research that I focus on in Stockholm as well. I have included a lot of material also in general on precision, personalized or individualized medicine, and let's hope that we have a better understanding of what those mean in the end of my talk. So if you start on personalized, you know, a cancer diagnosis is always personalized. It's always a very personal information that you get, and that has been so for ages. It's not something new. Cancer diagnosis is based actually quite a lot on imaging. If you think about getting a sample by surgery or biopsy, it's the pathologist that looks at the scoring, and now I've of course highlighted the Gleason score, which is used in prostate cancer, and it's actually the structure of the glands, the prostate glands, that will tell you about the severity of the disease. In prostate, you also use biomarkers, and PSA, the prostate-specific antigen, is one of the most known ones. But you know, there is an ever-ongoing quest for the best biomarkers to be measured from blood or urine or other more accessible areas to actually, by lab tests, determine if you have cancer. But then there's of course imaging of whole organs, like with magnetic resonance imaging that I have an example of here. Trying to actually see if you have cancer. So personalized in itself is nothing new. But what's the hype then on personalized medicine or individualized or precision medicine? You can see there really is a hype if you look at the number of publications during the last years on these two terms from PubMed. There is a lot of hype building up around this. And what we actually mean is bringing molecular and systems level data into the knowledge of disease, trying to look at omics and including that into the diagnosis and treatment decisions. And as of 2015, well, the previous president declared this program on precision medicine, and now remains to be seen whether this program will be continued. I truly hope so. And this precision medicine initiative is not only cancer focused, it's actually focused on all types of disease, also including measuring health devices, actually like preventive medicine in that sense. Of course, a lot of the precision medicine hype has started a long time ago with the HUGO project being finalized in 2003 and going on from having lower and lower costs on genome sequencing. And already in 2005, the NIH in the US launched this comprehensive effort to explore oral genomic alterations in the human tumors, and this is perhaps known to you already. But there is Genomic Data Commons, a data platform where you can actually find results that was published this June in 2016. And I picked up some numbers from this Genomic Data Commons as to what can actually be found there. So you see it's quite a vast number of different tumor types, 33 common tumor types, and 11,000 patients, which is a very impressive number. There is also clinical information on some of these patients, and there is actually 7 different data types, and we'll return to that later on during my talk. So inspired by this TCGA project, and you know there are numerous publications arriving now based on this data. There are now international consortia working towards the same effort, and this is now 22 different countries in the ICGC trying to basically do the same and increasing the numbers of tumors as well. So there is a lot of data gathering effort internationally right now to understand and list everything which is wrong in cancer. But still, and this is also now reshaping the clinical trials. So even if there is a lot of data being listed, that doesn't necessarily lead to increased knowledge, as you all well know. But this possibility of doing molecular profiling is also now changing how clinical trials are being made. So there are maybe 2 main types of trials, the umbrella and the basket ones, where you actually either then focus on one cancer type, do biomarkers, as here, and then the biomarkers will decide on which drug you would be getting, or the other way around, that you have several tumor types, as in the basket trial, and then do biomarkers and select drugs. My personal favorite is actually an adaptive trial. I haven't heard too many of them yet, but there is an example called TAPUR, where they choose 10 patients in the first arm, and if they have a signal event, that is that the tumor decreases to some percentage that has been decided, they will include 18 more patients into that arm. And now I don't remember the number. If there are enough successful signal events in that arm, it will be continued. If those criteria are not met, those trials will be terminated. So it's like a learning system on if you get enough patients that respond, you will continue that particular arm. But that needs then, of course, that you have several different drugs as well. So bringing in several pharma companies into collaboration in agreeing to giving drugs. So there is a nice publication describing the TAPUR trial by Shadrankar. But clearly they state there also that there has not been agreement between the parties on how data will be shared. And this is, of course, the difficulty in that how will these types of results be published? Will the pharma companies allow negative results from such trials also to be published? So even if there is a lot of hype building around precision medicine, which is perhaps my favorite term, there are a lot of critics also now being published, which is very warranted. Because a lot of these trials, the biomarkers are based on genomics only, and we know that a cell is much more than DNA. And a lot of the targeted drugs being used only have small patient groups that are being showing efficacy in a small group, and then resistance arises quite quickly. So I do think there is a lot of work still within the field of precision medicine to be done to actually show clinical utility, that this is improving things, but that doesn't mean that we shouldn't try. Most importantly, I think I like this publication from Rubia Perez and David Tamborero, where they actually then took a lot of these cancer cohorts, here including now 4,068 tumors, and looked, if you look at all the driver mutations in this cohort and predict which drugs you would actually give to these patients, there is only around 5.9% of the patients that would actually have a treatment based on a driver mutation. So you see it's a very limited group of people, and that's now the approved drugs for a specific indication. If you start repurposing, meaning that you, for instance, use a renal cancer drug for a leukemia patient, you do increase that to around 40% of the patients. But still there is a lot of new drug discovery to be made before we can target all those 4,000 patients in such a cohort. And maybe importantly, we need to include other types of data as well, not only looking at genome. The genome will never tell you whether a drug will work or not in a sufficiently precise manner. So here's a definition that we in our group like to use on what precision medicine really is. And I'd like you to read it, but I can read it out loud as well. It's about collecting, connecting, and applying vast amounts of scientific research data and information about health to understand why individuals respond differently to treatments and therapies. And then to help use that to guide, to give more precise and predictive medicine. So even if the TCGA data included all these 7 data types on DNA, copy number variations and mutations, of course on mRNA, on gene expression, and DNA methylation, and microRNA and proteomics by using the RPPA platform and clinical data, that is not being used too much in the clinical trials that are being done today. And as a high throughput screener, what I of course miss in that is the cell-based functional testing entirely. There are platforms now and publications, also very debated ones, being published on specifically on drug testing in cell-based assays, and there is a lot of controversy on whether that is a reliable way to measure. I do think so, and I hope that with the next slides I'm able to convince you that as well. So now we come to the Individualized Systems Medicine, which is a strategy that we've used at the Institute of Molecular Medicine in Finland, FIMM, for the last years, which entails, of course, and it was started on leukemia patient, and it really involves, we call it living biobanks, because it's not biobanking material as such, but it's actually living material from the patients being used real time in the research lab. And then, of course, the clinical data. And we do what others also do, genome and other omics profiling of the tissue and cells. But in addition to that, we work on what we call ex vivo material, which is patient-derived cells, and do these functional tests as comprehensive drug profiles. This was, as I mentioned already, started in leukemia. And in leukemia, you can appreciate that the material is more readily available, either from the bone marrow or just from peripheral blood. And the patients arrive usually to us in these stages, but we are now also starting to get diagnostic material. And they undergo, as I mentioned, the different types of omics profiling. They are linked to national biobanks to kind of preserve their samples as well. And then we perform this drug sensitivity and resistance testing. And that is actually being fed back to the clinic in real time. And I just got these numbers from Olli, in that in 74 relapsed and refractory samples, meaning patients that have already had a second turn of leukemia and that have had all treatment possibilities tested, these are usually the samples that we get, that 17 out of these have actually been treated based on our drug sensitivity and resistance profiling. And the patients were given either targeted drugs or combinations of these. And in 35%, or let's say 6 patients, this has led to remission or what we call a morphological leukemia-free state. It doesn't mean that we have cured anyone. We have given them months to continue based on the type of profiling that we do. But I'm not going to talk about leukemia more today. I'm just going to describe first why this is more difficult in solid tumors. So when I started 5 years ago at FIMM, my task was to try and push this towards solid tumors, and I had worked as a postdoc on prostate cancer, so the choice was obvious that I would try and push it towards the urological tumors. Unfortunately, you don't have pleural effusions or ascites fluid, which means it's like this body fluid contained with cancer cells, as you would have in ovarian and lung cancer. And we do have a very successful program on ovarian cancer in the group as well, where you can get this ascites fluid with cancer cells to be tested directly. As another senior in the group, Taija Hellström, she had expertise on tissue culture slices, meaning that you actually grow thin slices of tissue directly on titanium grids for 7 days. But we calculated that that would never allow us to do enough throughput for our library, which at that time consisted of 306 drugs, but we would have been able to test maybe 60 drugs tops using that platform. But at the same time, in 2012, came these publications on this conditional reprogramming of primary cells, and we decided to test that because that would, according to the publication, we would get enough material to do comprehensive drug testing. So I've outlined here basically what the conditional reprogramming protocol does. I don't claim that I know or understand exactly what it does to the cells, but it's a way to make stem cell-like, or they proliferate like regular cell lines. So we are getting rid of the hurdle of primary cells stopping to grow after a few divisions in culture. So basically you get different types of tissue, and we tested here radical prostatectomies, which is from the operation theater. You get the whole prostate. Or then transurethral resurrections, or TURPs, which is using a laser through the urethra. That's when the man has already problems to pee, so you can use a laser to cut the urethra open, and then you get material that looks like this. Or then needle biopsies, which are taken through the rectum into the primary prostate cancer. You cut these tissues into pieces, you collagenase, you basically make a single cell solution overnight, and then the culturing is done within 3 to 4 weeks in the presence of this old-fashioned Rho kinase inhibitor, which probably has other targets than Rho kinase as well, and on irradiated 3T3 cells, which are mouse cells, and they are irradiated so they don't grow. So they basically provide a substance for these cancer cells to grow on. And after 3 to 4 weeks of the cell culturing, and we tend to take from the same patient benign material, cancer cells. If there are any metastases, that's also interesting. So we tend to generate many models from one patient. We do the drug profiling, but at the same passage of cells, we also do genome profiling. And this is because we know that the protocol changes these cells. If you put human cells to grow on plastic for any amount of time, it will change the cells. So we are careful to do the genomic profiling at the same passage of when the drug testing is done to make sure that we retain some of the original genome of the cancer in the cell models. And this is what we call our quality control of the cell models. So now to the drug testing platform. So the library that we've used in the prostate cancer study was 306 drugs, but currently we're working on a library which has 525 active substances. That means that it's all the approved oncology drugs, but also most of the investigational drugs. And we also have a lot of proprietary drugs directly from pharma companies included in these. They are all plated on 384 well plates in 5 different concentrations using acoustics. So we ping 2.5 nanoliter droplets of the drugs into the plates. And then the cells, leukemia cells, of course, directly when they arrive from the clinic, or then for solid tumors when they have been grown for 3 to 4 weeks, are added by a simple peristaltic pump into all the wells and grown for 72 hours. After that, we measure, this is the standard measurement, viability or toxicity. So it's luminescence or fluorescence, measured by cell titer glow or a cell tox screen using simple plate readers. But we also, and then we've developed a specific score, which is published, which I like quite a lot because it's not using only IC50, but it's an area under the curve. It's a multiparametric score, taking into account the IC50, the minimal and maximal response. And we get a very simple score by which we can rank our results. In addition to these very simple metrics on viability and toxicity, we of course are developing other more advanced endpoints, including then image-based screens and the flow-based specifically for leukemia samples. And I'll hopefully come back to the image-based screens later on. So what the patient basically gets is we do the samples, we do the screening in 384 well plates, 3-day assay, measure toxicity, and then we get all these dose response curves from each drug. So we have around 300 to 500 dose response curve per patient or per sample that we screen. And we generated a semi-automated pipeline, so any biologist as myself are able to input the data directly into the web-based tool and get the drug sensitivity scores, do my own heat maps. So it's really point and click, no coding required. But it's an open platform within FIMM, and we're now also bringing that to SciLife Lab and putting it in the cloud. It's currently linked to an Oracle database, but we're hoping to get rid of that soon. Why I'm mentioning this, it's important because the database contains a lot of control samples. So we have a lot of healthy bone marrow, for instance, which is used in the leukemia cases as a control. And in the solid cases, we also, of course, try and use the benign samples. But the control is really important because otherwise you're just measuring toxicity of your drug. So we always do a differential. And basically, this type of a patient-specific drug report goes to the clinician involved in leukemia in 4 days and in solid tumors in a few weeks. Listing that you see here is a selective DSS. This is the drug sensitivity score. And then highlighting the IC50, then we have the mechanism, the supposed mechanism of the drug, and then which phase that drug is. And that's then for the clinician to be used whether they deem beneficial or not. So I'm going to go a bit into the prostate cancer study that we've done, which was done on 7 patients, and they're listed here. And this HUB stands for Helsinki Urological Biobank. And we chose, as I mentioned, different types of material. These are the radical prostatectomies, the TURPs, or the needle biopsies. But I'm only going to focus now on HUB5 here, because this was the only treatment-resistant case that we had that actually had matches in the genome to the original tissue. And I'm not going to show that data now, but you can look at it in the publication if you're interested. But this is what the drug profile of the HUB5 looked like. So you have the typical cell lines from prostate cancer being clustered together with the HUB5 profile, suggesting that this was the most aggressive model that we were able to generate. And then back to the question of controls. Here we have used the mean of 2 benign samples that we had from before. So this is a benign from different men. But then we also had benign that were developed within the project. And we compared the specificity of drug response in HUB5 in comparison to these other controls. And in both cases, it was these 5 drugs that showed the best specificity for specifically killing the patient HUB5's cancer cells. And here are the dose response curves for three of the drugs. We were most intrigued by the navitoclax drug, because we could also see an elevated expression of targets for navitoclax, which is the BCL2 pathway, so in this patient. And I'm just going to summarize next here that based on our first pilots on prostate cancer, 8 out of the 10 attempts in growing cells using conditional reprogramming worked well, meaning that this is a very powerful method of getting primary cells to grow, but meaning also that you need to be careful of what you grow, because you will grow benign cells if there is a lot of them present in the sample. Now, in 2 of these patients, we were able to retain genomic similarities to the tissue. And in 2D cultures, these had a stem cell-like phenotype, meaning that they are androgen receptor negative. If you put them in 3D, we are able to differentiate them and start expressing androgen receptor. But I'd like to use it as an example of how a patient could benefit from being profiled in this functional way, in that this was a patient that had a very high Gleason score, a very far gone disease. He was treatment resistant, meaning that he had all these treatments already, which he didn't respond to. And based on our screening, there was the sensitivity to navitoclax, and there would actually have been a trial available where a combination of navitoclax and abiraterone, which is one of the main androgen inhibitors currently in use, where this patient perhaps could have participated. Sadly, he was deceased before we had the results, as these are usually quite old men. But at least it was indicating that we maybe are onto something, that this is something we should continue. And I was specifically asked to talk about data challenges in my type of research. And the challenge is really here. So, I mean, it's not a hurdle specifically with SciLife platforms to get omics data. It's about the integration, about understanding, and about collecting that type of different data. Very, very practical issues, that how do I find all the information there is about HUB5 and which all platforms has it been tested on? And if it's difficult for me, it's going to be impossible for the clinician in the project to try and find this. So I don't know if you are the correct crowd to solve this, but this is really, really like everyday practical problems on trying to collect and even visualize to try and find the outlier patients and the specifics of one. So I added a few pointers on what next, as I really feel that at least right now we are very much in a setup phase again. So in ovarian cancer, we have had 2 patients that received treatment based on ex vivo profiling. Actually, one of them was in Estonia and one in Finland. And this is a project that Astrid Murumägi, another senior in Helsinki, has been working on. And we are currently working mostly on renal cancer, where the models seem to be more easily generated than in prostate. Because in what the prostate cancer study showed to us is that you need to really work on aggressive material to generate valid models. So we are now focusing on metastatic treatment-resistant patients in Stockholm. Yes, and since the 1st of September, I've been at the SciLife. And so far, we are, including myself, we are 3 more people, Brinton and Elisabeth and Natalia. And we have the first cell cultures going on. It's not patient-derived cells yet, but testing if the incubators work, if the laminars work. So we have a basically operational lab as of this week. But the biological questions that I want to work on and understand more, and what our small pilots on image-based drug testing from FIMM has shown, is that there really is a vast heterogeneity in the drug response. And we are very much now working on developing models from some patients that are already have a metastatic tumor, so that we can get several types of models developed from one patient. And this is now a phylogenetic tree that we've generated based on genomic profiles on how the benign tissue is linked to the models, and how the models are linked to the original tissue. So we can see, like for this metastatic cell, or this is a cell model, it's very close to its metastatic tissue. So I'm very happy about this particular patient's cell model. And in seeing this type of a tree and then having the drug responses done from each of these cell models, we can start thinking about clever combinations on actually treating the metastatic clone and treating the primary clone as well. So, in addition to just measuring viability, we also then work on imaging, and not only cell imaging, but also doing digital pathology, actually looking at on a single cell level using multiplexing in tissue, and this is something that Teija Pellinen is working on. And in the same patient, linking to what the cell models from that same patient looks like, and this is where Vilja Pietiäinen is the primary driver. Yes.
I have a question there. So when you talk about the metastatic cells,
yes.
Do you usually then have one cell model per tumor, or do you do several parallel ones?
Yeah, so far we've done one per tumor. I would love to do 10 per tumor, but so far for the renal cancer cases we use actually genome-wide sequencing, so it becomes quite expensive to actually characterize 10 models. But that's something that I would be very interested in, actually looking at how do the 10 different models, which is the best representation of the tumor of origin. But this is shortly then on what we've done. This is a project that Carolina probably have heard about already, in collaboration with Peter Horvath, but this is now very FIMM based and using a scanner microscope, a very basic high content automated microscope, and building up a pipeline around the same renal cancer patients on doing imaging actually after drug testing. And then of course, as we are now located in actually 3 different sites, we are working together with Microsoft on a project to develop different types of cloud solutions to enable our analytics and storage in all different sites. And this is perhaps not new to you, but I'm very fascinated about the final number actually here, in that I do think that imaging will help us understand heterogeneity much, much better, because also it's such a data-rich endpoint, and that's why I'm very happy to be here today and hopefully have fruitful discussions on how to solve this issue of finding clues in the data of imaging. And this work was of course not done by myself, but there's a large group of people listed here. First of all, of course, the patients that have very generously provided their tissues to our research. And this is our group, so we are about 20 people in Helsinki. This is on the boat between Sweden and Finland, where we had our retreat. All these actually missing. And none of this works, so the whole leukemia project is really about team science. These are 2 big projects for any single research group or PI to do alone. So this involved many groups and clinicians. These are the leukemia clinicians, and it's really Kimmo Porkka, who is the head of hematology, who was the driver of this. And then this is Antti, who is our urologist, and Tuomas, who is the uropathologist in the project that have been key. And we have now managed to get new good clinical contacts at Karolinska Hospital that are eager to initiate a similar project. And yes, we have a first drug profile measured at SciLife, so hopefully we'll soon have patient-derived material grown as well. And this is really where I'd like to conclude, in that we should not work in solitude. This is a very describing letter from the textbook of systems biology. If we're ever going to solve and get across the valley of death, this is very much needed. So if you're interested in collaborating with our group, feel free to be in contact. And that's where I stop.
Thank you so much. Time for some questions.
Very general question. So what? I mean, obviously, from your example there with the prostate, it would be nice to reduce the time.
Yes.
From
Yes.
finding this resistant tumor to actually figuring out what drug to give to the patient.
Yes.
What are the most time limiting? What takes the most time? What is the bottleneck?
I would say it's the cell culture. I mean, it grows as quickly as a cell line, but to get enough material, you still need to grow it for 3 to 4 weeks, depending on patient and depending on tissue. If you have enough ascites fluid, you could use that directly. But then, in really practical terms, it's been informatics, getting everything done and getting everything integrated and analyzed. And I'm hoping that we'll do better now in Stockholm as well on that respect. Specifically in the prostate cancer case, the models that we generated were mostly benign, and the genomics didn't represent the cancer that patient had. But the patients didn't have mutation-driven cancers to begin with. So that we learned, that you need to have a genomically driven cancer to be able to QC the model. And that's why we're now going after the metastatic prostate cancer. In renal cancer and ovarian cancer, you have much more pronounced driver mutations that can be seen in the cell models. So that's maybe the bottlenecks there.
I have a question, not a question, but I just want to know, like you spoke about this umbrella style.
Yes.
Style
Yes.
one. As you said, like in the adaptive one, first you have 10 patients.
Yeah.
And if the results are good, like then you will add 18 more patients. But what if, like in the 10 patients, you didn't get any patient, then how you will select the next 18 patients?
I mean, then that trial, if there's no signal event, it's concluded. It will.
It's possible that the patients you got is
nothing's.
The patients as well.
Yes, very much so. But these are the new types of trials being done right now, and no one knows if they will prove anything or. Yeah.
One more question.
Yeah, sure.
Like you said about AUC, like you are getting this measured, like AUC.
Yeah.
But only having AUC as a measure, it's not like a bias situation.
No, I agree, but it's not only an AUC, it's including an AUC. Yes, yes.
If you see, you talked about 300 something drugs that
Yes.
you're profiling at the moment and 500 in the other
Yes.
example. If this is going to be used in clinic
Yeah.
for all patients,
Yes.
how do you see, what would be a sort of a number that would be?
Well, if you remember the list for the example, it was a renal cancer patient. Only, for example, 3 of the drugs on that list were approved. Then the clinician most likely would use an approved drug, even like perhaps a cross-indication drug. And in the ovarian cancer cases, this was actually the case. And they asked the drug from the pharma company, and they actually provided that drug then to that patient. But there's definitely an issue of liabilities, about cost. But that needs to be solved then per patient. I mean, so far we're not doing clinical trials based on cell-based functional testing, although I would like to do that someday. I mean, this is very much criticized within the precision medicine, that how can we afford?
But I have seen an example from Finland where it has been used in clinic.
From
Well, I don't remember his name.
I mean, but the drugs in leukemia, I mean, in the 17 patients that have received treatment based on these, they have been, I'm guessing now that there are mostly approved drugs still, that it's mostly within the approved spectrum that you're allowed to do. But then you can do a lot of interesting research based on the investigational drugs, and the pharma companies are very interested into looking into that type of data, linking their new drugs also to.
I mean,
Yeah.
drug repurposing, you
Yes.
could be using drugs
Yes.
meant for something else.
Yes.
There must be very limited ethical issues in you know.
Well, it's been used in compassionate care settings.
Yeah.
Yes.
I have another question.
Mhm.
Those 5 drugs that you pinpointed in
Yes.
your plot,
Mhm.
if I look at the plot, I cannot say immediately why you chose those 5.
Well, it was based on the RNA sequencing data that I didn't show you. Yes. Yes, so I minimized the biological data in the presentation.
Can you go back to that?
Yeah.
Because I also had a question. I didn't understand understand it either.
Let's see.
Here. So you have all the different colors, but I only see black and white. But maybe.
Yeah, it's a very. You can see it on the screen, perhaps better. But it's basically these drugs being here in the red area.
So
I'm sure that doesn't answer your question.
But I mean, each marker has different color, but I
Yes.
can't see them. Okay.
Yes.
Okay.
Yeah. So these were the ones that were most specific for that specific drug in comparison to the controls being used. And then we try always. Yeah, and we try always. Yes, yes, and we try to always use for solid tumors. I haven't resolved the question of what is the perfect control. So we try and use different types of controls and try and stay with the drugs that are consistent with the different types of controls.
Did you try combination of drugs also?
Yes, we did actually. It was a referee question. So we do, because of the acoustic dispensing, we are very flexible in doing different types of drugs, and we also have a synergy score for doing 3x3 9 concentration in our automated pipelines, and this is something that we quite often actually do. But it was for the referees only in this case, and not included in the publication. But this is something that is being tested, not as a screening phase. There have been a few screens done, like one drug against the whole library, but it's something that then if you find interesting combinations, you do the synergy score and try and find. So I should mention then the group of Tero Aittokallio, who is the informatician crew in the team science effort here. So Tero is the PI over there. He's developed a lot of the scores, and including the synergy score, and the YADA publication on the drug sensitivity score is from his group. So it should perhaps have been him presenting this type of work here instead of me. Mm-hmm. Yeah.
I have another question about when you talk about the sort of phenotypic screening.
Yes.
When you look more at different
Yep.
features.
Mm-hmm.
Do you know anything about what kind of features you're looking at?
Well, I've learned that much, that you can get any feature you want, and you can get a lot of features. But which one of them will be the most, the one that makes sense? I don't know. I don't have an answer for that. Of course, I'm looking at it from the angle of which antibodies we should be looking at. And as most of our results so far come from viability testing, it's an antibody called Ki67, which measures basically the cell cycle of the cells, but it's also used in the clinics by pathologists to determine the severity of the cancer. So I think that's a good start. But hopefully, we should be working on a lot of antibodies looking at the differentiation state and such. But that's then another type of question as well. So we try to divide it into phenomics, which is like looking at the phenotype in itself, but that's not then including drugs. And then looking at a few markers with drugs, where you could possibly then find which phenotype or which feature would be the one that determines outcome. Mm. Okay.
Okay, thank you so much.